Hello, my name is Maureen Lefton-Greif, and I'm a professor in the Department of Pediatrics and Otolaryngology Head and Neck Surgery at the Johns Hopkins University School of Medicine. By training, I'm a certified speech-language pathologist, and my clinical work and research have focused on swallowing disorders that develop early in life. Dysphagia is the term used to refer to swallowing disorders. It is well recognized that the incidence of dysphagia has been increasing in the pediatric population. It is also well recognized that the early detection of these problems and the prompt initiation of treatments can decrease the downstream consequences of dysphagia, which are not trivial. Dysphagia can contribute to lung disease when foods or liquids are aspirated or go down the wrong way. Another consequence can occur when dysphagia interferes with infants and children getting the nutrition they need for growth, brain development, and their overall well-being. In addition, dysphagia can cause stressful interactions between children and their caregivers, and it can cause social and economic burdens for the entire family. Currently, the primary test used to evaluate for the presence and extent of swallowing dysfunction is an X-ray swallow study called the Video Fluoroscopic Swallow Study, or VFSS. The VFSS is an X-ray exam that allows us to see the parts of the swallowing mechanism function during swallowing, which are not visible on clinical exams. It shows how these structures direct liquids and foods from the mouth into the stomach while infants and children are swallowing. We can see whether foods or liquids are directed the right way or if they're aspirated into the airways. And we can determine whether swallowing function is efficient for children to meet their nutritional goals. We've come a long way with our understanding of pediatric dysphagia and its consequences. However, despite this progress, and despite the VFSS exam being considered the gold standard for the evaluation of swallowing dysfunction, we have been without a standardized and validated approach for reading, interpreting, and reporting the findings from the VFSS exams performed in some of our most vulnerable children. This lack of standardization has caused unnecessary or excessive variability, which in turn appears to have increased the number of exams that children receive. More exams mean more exposure to X-rays. And potentially, this variability has led to a decrease in the accuracy of findings reported from these exams. So, to increase the clinical and research utility of VFSS exams and decrease the consequences related to unnecessary or excessive variability, my colleague, Dr. Martin Harris at Northwestern, and I conducted research that supported the development and validation of a new tool called the BaByVFSSImP. The BaByVFSSImP supports the detection of essential components of swallowing, which are critical for airway protection and bolus clearance through the pharynx. And it enables quantification of physiologic impairments in these components during swallowing. As to its clinical utility, the BaByVFSS is a novel and validated tool that can elevate the care we provide to bottle-fed children with dysphagia and optimize their outcomes. In addition, in the future, it can be used to identify phenotypes of swallowing impairments in specific patient populations. It can help direct interventions to these physiologic impairments. It can provide objective measures for dysphagic interventions, and it can also provide objective measures for functional outcomes and metrics for future research. Again, early identification of swallowing dysfunction and the prompt initiation of interventions that are directed towards specific swallowing impairments are critical. The BaByVFSS is a novel tool that can inform clinical practice, future research, and most importantly, improve the outcomes for bottle-fed children with dysphagia.